Today I'm going to be covering post-operative prostate, which my understanding is for most of you, and the same for me, it's much less common than intact prostate. But I think there's some easy things once you've gone through it a few times to help simplify contouring and so forth. So I'm going to try and keep things simple and take you through indications why we're doing post-operative treatment, CT simulation, and then really get into it with some clinical cases that I've set up ahead of time and then close. So throughout the talk, feel free to include your questions. And actually, one thing I did is somehow I lost my little chat. So
sometimes, yeah,
okay.
I will be the eyes on the chat box, so
Okay.
don't
Yeah,
worry
if
about
there's
it.
anything, okay, perfect. Yeah, if there's anything, feel free to type in at any time. I'll also take more questions at the end if you prefer to talk about it there. I'll be going back and forth from my slides to also some cases that I've set up. And I truly believe in lifelong learning. I'm still learning. We're all learning all the time. So any questions, no matter how simple or complicated, are welcome, and I'll do my best to answer them. So this may look somewhat familiar if you were here last week with Dr. Longo. I'm living in Milwaukee, Wisconsin. I was previously in New York. We're very close to Chicago, which is right about here on the map. And I work at two different hospitals. One is the Medical College of Wisconsin, and then also the Clement J. Zablocki VA Medical Center, which services veterans. Global health has been a passion of mine throughout medicine. I was fortunate during my training to go to Botswana, where I got a little bit different taste of how radiation could be done in different centers. And I learned so much from the crew. And it was really an eye-opening experience where I just felt like I learned so much from them. So one of my goals in the future is to do more global medicine, but also to contribute to the community any way I can, be it in lecture series. But I feel that connection sort of worldwide, and we're all just trying to help each other. So one reason why I'm glad to be here today. At the medical college, I practice mostly thoracic and CNS radiation oncology. And at the VA center, the way it works is we're all generalists, where anyone who comes in with any kind of cancer will treat. The most common type of cancer I treat over there is prostate cancer. I also do prostate cancer research. So one of my first questions, if you don't mind, is for all of you. So I'm curious, within your practice, how often do you see prostate cancer patients? Is this a small amount, or give you a minute to respond?
Great, feel free to respond, and we see the answers coming in. So less than 10%, 10 to 25%, 25 to 50%, or greater than 50%. Okay, we'll give 5 more seconds. 4, 3, 2, 1.
Great.
Okay, and Dr. Puckett, can you see the results?
I can, yeah. So it looks like, and I don't know if this shows up as sharing too, it looks like most of you have less than 10% of patients who are prostate cancer. So that's great to know. And, potentially for some of you, then it's pretty rare. I see a lot of 10 to 25%, which is, I think, also fairly common, some in the 25 to 50% range. We have 16%, and just a small number who have greater than 50% of cases. Oh, there's the upper, okay. Now, there we go, and I'll close that one out. Okay, that's helpful to me too, because if it's a more rare number that, at least for half of you, you're seeing less than 10% prostate, and then on top of that, or post-op, it is more of a rare patient. So hopefully, again, that makes me feel good that what I've prepared is sort of on board to make you feel more comfortable and take you through some of the basics that you would see. In our practice, when we're in the post-operative setting, we usually do IMRT. It would be a rare exception where we do something else. We treat much more intact prostate. So our post-op is probably about 15 to 20% of our overall prostate patients. We see a large number of high-risk patients at the VA. So it's also common that we'll be treating nodes, and you may see that in some of the plans. For mobilization, we use a VacPix, which is just a vacuum bag. It's similar in nature to if you have an alpha cradle or something else. Otherwise, I've also used knee fix, but we don't do that. We're at the center I'm treating at. Generally, we pay a lot of attention to the bladder and really try and get a full bladder. And if it's not, then we'll try a second time. And for post-operative doses, they tend to be in the range of around 66 gray, sometimes a little bit higher or lower depending on anatomy. And then again, nodes if it's indicated. So one other question for you off the bat. So among your prostate patients now in that pool, how often is that post-operative for you?
Okay, again, you should see the Zoom poll. So is it less than 10% of your prostate cases are post-op, 10 to 25, 25 to 50%, or more than 50% of prostate cases are post-op? Take a moment to respond. We see a lot of responses. Okay, we'll give 5 more seconds. 4, 3, 2, 1. And sharing the results.
Great.
There you go.
So yeah, thanks so much for participating. It's really neat to see sort of the spectrum of what people are having. Looks like almost 60%, less than 10% of cases. So, this is actually a smaller number within clinic. But again, if you do have it, you want to be able to be comfortable. And then again, a smaller, I'd say very few above 50%. So that's helpful for me. Okay. So when you're seeing something that's more rare, if you're like me, it's like, oh gosh, where do I even start? I haven't done this in a long time, or I haven't done this ever. And so usually the way that I'll do it is I'll totally refresh myself. So I'll go back to my basics and review whatever resources I have. And so ahead of this lecture, you should have gotten several, one being the main RTOG contouring booklet. There was previously an atlas that was online that temporarily seems to be down as well. One other resource that I like to use is eContour, and actually that was one question I had for Ben and sort of the group, is just to make sure that that is widely available. I know we have the prostate fossa part of that included in the resources, but hopefully others are able to access that as well. And this is a nice lecture too. I don't know if, I know you've had a whole series on more basics and pelvis too, but any basics of contouring, if you're just starting out or in a resident level, sometimes it's nice to review that as well when you're going into something you haven't done frequently. So this is from that Mahalski Atlas back from, I think it's from 2013. And what they did is they had 11 prostate experts all contour a post-operative case. And these are their different contours that you can see here. And it's sort of reassuring in a certain way of even experts have variation in how they're doing this. So creating consensus contours are helpful for all of us, but also there's truly variation and not just one way to do things. So also sort of in the theme, so you do have a patient who's undergone prostatectomy and they come into your clinic. I'm just curious, when are you going to add radiation?
Okay, so the options are A, everyone needs it, B, positive margin, C, extracapsular extension, D, seminal vesicle invasion, or E, positive margin, ECE, and seminal vesicle invasion. I like this question, Dr. Puckett.
Oh, good. Yeah, just a little bit of level setting ahead of time, and these responses look good.
Yeah. Yeah, interesting. Okay, so we have about 90 people have responded. We'll give 5 more seconds. Go ahead, say whatever comes to your mind. 3, 2, 1. Okay, and yeah, I think this will be interesting for the audience to see.
So the good news is everybody is right, or at least part right. I was making sure not everybody needs it, but there certainly are indications. Positive margin is one of the most, so I'm not mad that some of you selected that one alone, because that is very key. However, extracapsular extension and seminal vesicle invasion are also indications for it as well. So any of those or any combination of those. Great. So with that in mind, your postoperative contours are not going to be a one size fits all. Not that any prostate or any type of contour is exactly a one size fits all, but depending on the features that got them to your clinic, we may do it a little bit differently. One key thing within that is to read the operative report. Within that, you can find, well, where was the positive margin? Was that near the apex? Was it near the base? Were both seminal vesicles involved? Was it all on one side? Those will help you to really tailor your treatment appropriately and prevent recurrence. There's also some new and evolving indications, but really I'm going to shy away from those for now and stick with these. This is from the NCCN guidelines, and I just wanted to point out a few things too. In the instance of sometimes you will get them where they have persistence or recurrence. Sometimes it will be immediately post-operatively, but depending on life expectancy, you would consider slightly different treatment. And within that, they mention several types of risk stratification and imaging. Bone and soft tissue can be done in several different ways. There's also things like PSMA and MRI, which are less available. And so I'm not including those in here really today. I'm focusing on CT since that's sort of a unifying feature that I would expect within pretty much any site that's treating. And again, external beam radiation and ADT for most of these patients are going to be what's indicated. So this brings us back. This may look a little bit familiar from the past. And now you're most of the way through your lecture series. So you may have some different things to say than you did back then. But what it's looking here is in respect to the inferior aspect of this, with the green being the bladder and the brown being the rectum, which of these is the correct way to contour?
Okay, so A, B, C, or D. You have a 25% chance of guessing correctly, and maybe even higher. Okay, good. Answers are coming in. And if you're scratching your head, this question is meant to be tricky. So it's showing one way that's the most right, and then other ways that we've seen that are common, but hopefully this will help you refine your technique. Okay, we have 80 respondents. Go ahead and put in an answer if you haven't yet, and we'll close in 5, 4, 3, 2, 1. Okay, here are the answers, or the results, I should say.
Great. Yeah, and thank you for participating. So this looks like a good first start. And as we go through things, hopefully I'll come back to these at the end and we'll go through which one is correct and then also the others, why, they might have been drawn that way and how to adjust. And my hope is through the cases and whatnot that it'll be more clear. So that's good. And then we'll do one more that was the sister question to that. So which of these is correct with regard to the CTB and the bladder? Back-to-back questions. Thanks again for participating.
Yeah, we're putting you to work, everyone. Thinking caps on today. So this is a sagittal view, post-op prostate cancer. The green is the bladder, the brown is the rectum, and then the CTB is shown. So is it A, B, C, or D? Okay, answers are rolling in. This is great. We're up to 75 people. 80. 85. Okay, we'll give 5 more seconds. 5, 4, 3, 2, 1. Okay, and this is the group.
Great. Yeah, so it looks like a bit of a split too. And so that's really wonderful because this one especially is one that I want to not burn in, but it's a really great learning tool. And this is one of the most helpful images for post-op prostate that I use to know if I'm on the right track or not. So I'll come back to that in just a second. So, and you'll have to forgive me because it's not the most elegant tip that I've ever had. But in general, when you're doing a post-operative prostate in this plane, it will look like sort of a Western toilet. And so if you look through these, you might spot one that looks more like the others. And the reason why is it's coming up here, and then you also have this bridge up here. And so this is how it was taught to me. And I do, when I look at this plane, I almost always know if I'm in the right direction. So we'll come back to that, but my least elegant tip.
And you want
Um,
it as if you're sitting on the toilet seat. So the top is at the back.
Correct. Yeah. So, and there's always a little bit of slope. So you have to use your imagination just ever so slightly with it. Now, for me, I did include this slide of prostate anatomy, but of course, the prostate's gone. And so it creates a little bit of a mess. I mean, there's standard things that we can do, but we sort of, knowing what's there to begin with is really helpful to know how it will then come together at the end. And I'll come back to this a little bit more. When you're orienting yourself, my biggest tip for post-op is that you're going to want to use all three planes. As I mentioned, this is actually the one that in many ways I find most helpful. Normally, when we're contouring, axial is our, I don't want to say be all end all, but pretty close, where it's so important and we're most used to contouring on an axial plane. Below and above the pubic symphysis, there are different borders in this. And so that's something we'll pay attention to, and I'll go slowly through each of those to get some practice. In the first step, I will just sort of go through CT simulation because there are a few special considerations for post-operative treatment. By and large, you want to have something that's reproducible and tolerable, and different centers can do that in different ways. We want to treat the prostate bed and also not have more overlap than is needed with critical structures or organs at risk nearby. When we're prepping, we almost always have a full bladder, just like we do for intact prostate cancer. And part of this is because it will push the bowel away. However, we also want a bladder filling that is sustainable through the treatment. If you get a very full bladder on the simulation day and then you can't repeat that, then you've done yourself a disservice and you're getting sort of skewed ideas of what your actual organs at risk are receiving. We work hard with our patients to give them instructions on filling, both timing and encouraging baseline hydration throughout their treatment. There's stimulants, which obviously become more important throughout their treatment. And one thing that often happens, and you have to be mindful of when someone has had a surgery, is depending on when they're being referred, they may still be early in their recovery period where their urinary symptoms are quite profuse. Over time, that healing process, it often does get better. So if there's someone I get who I get the sense that they haven't recovered in terms of their function, we will often give them an extra few weeks to see, are they improving? Because whatever that baseline is tends to be what they will have during treatment and afterwards. And if, for example, they're really struggling to hold their bladder and with a lot of incontinence early on, that's going to be a more challenging treatment for them to get. So definitely a consideration. And the other is when you sim, ideally you want an empty rectum, but again, your biggest goal is to have something reproducible too. So depending on the patient's individual situation, that may or may not be as feasible. I treat veterans who are, for example, homeless or having real issues with where they're staying and whatnot. And sometimes they don't have a lot of options as far as can they avoid gas-causing foods or what or when they're eating. So every situation is different, but obviously the more you can do to support and educate your patients goes a long way towards giving them the best treatment that you can. Next, for immobilization, this can be done in a number of ways. Either foam like an alpha cradle or a vacuum fix are very common. However, even a knee fix or a knee board where it's sort of holding the legs can be used. Depending on how exact that is will depend on your margins a little bit for PTB, which I really don't go in too much to GTV, PTV, CTV in this, more focus on anatomy, but just something to be mindful of. And I think pretty standardly, as with other prostates, they're going to be supine and generally with their hands on their chest. Oral
Dr.
contrast is
Puckett,
sometimes, oh, yes,
we have one question in the chat that's related
sure,
to the timing of radiation after surgery.
absolutely.
For someone that needs adjuvant radiation, how long do you wait after surgery before starting? Is there like a specific time, or do you monitor how the patient's function is doing with their bladder and base it off of that?
Yeah, good question. So at least in our practice, we'll typically wait at least 4 weeks, sometimes even longer than that, up to 2 or 3 months if they're having a very, very slow recovery. It's also a little bit individual with respect to how aggressive is their prostate cancer. For example, someone who was a high risk prostate who ended up having a lot of negative features, you may feel a little pressure to start them sooner, where someone, for example, who is a low risk prostate cancer patient with a single positive microscopic margin, then that benefit of waiting just a little bit longer for healing, you would have more of. So it is, I would say, a little bit tailored to the individual as well as, the situation. That's a great question.
Great. Thank you, Dr.
Thank-
Puckett.
Thanks. So with anyone you're going to do nodes, a lot of times we'll do small bowel because we're going a little bit higher in the pelvis. Otherwise, I generally don't necessarily use oral contrast. Contrast also with nodes sometimes is used. People will consider a urethrogram. In our practice, we often will get an MRI as well. And so the combination of the CT and the MRI generally gives us enough information where we won't also do a urethrogram, but it can really be helpful. In general, you're going to want a slice thickness of 3 millimeters or less. 2 millimeters is done, I think, at the centers where I am. However, I've also seen it with 2.5. And making sure that, especially in that key area, that you have those thin slices. And lastly, you want to make sure that you're covering enough above and below, and that depends a little bit, again, on if you're doing nodes. So for each of the prostate situations, there are RTOG consensus guidelines, which can be really helpful. And this one is Mahalski et al. And there's an image that I showed earlier, but they provide really our borders for what we're going to do. And I look at this, and this is a lot of information, and I sort of start to zone out when I see it. But what we'll do is we're going to break it down. There's borders above the pubic symphysis and there's borders below. And we're just going to take them one by one and go through. And it's actually not too bad. In general, I have a few contouring tips. Many of these I've learned from my peers and my co-residents back when I was in training. One is using your crosshairs or looking at all 3 planes, and I'll show what that looks like. It will recenter you. Sometimes scrolling in a different plane will really help you figure out, am I on the wrong track? Have I gone too far in a certain direction? And following the structure before your contour. So for example, something like the rectum, if there's an area where it's like, wow, that's really hard to delineate, we'll start at a place where you know, and then work in a different direction from there and see if you can figure it out. And then again, go back to your crosshairs and look in all 3 planes to see if that makes sense. Lastly, for post-op specifically, having some normals can really help to guide you as far as where your boundaries should be. In all of these cases, we're going to include the prostate bed. The seminal vesicles also generally are recommended to be included. For nodes, I put a few rules of thumb here. This is really controversial. There's definitely practices where they will almost always do them post-operatively, and others where it's much more stratified. By and large, again, you're going to want to know what type of disease the person had at the get-go. Was it a high-risk disease? Were there nodes involved? Obviously, those type of features would really make you think about including them versus our patient who has low risk and low suspicion afterwards, who had a single positive margin. that person may not need nodal treatment. So a lot of this has been covered in other lectures, so I don't want to belabor it, but because it has a specific to post-operative, I wanted to include these. And again, if for any reason you weren't on last week, just to refresh. So our lowest level is going to start at the level of the ischial tuberosity, and then we go up from there. And then upwards, we're taking it up to where it's round, and then ultimately where it starts to dive forward is where it cuts off. So we'll just look at that. And this is an intact case, but again, just sort of showing the normal structure. I wanted them in here so you could go to this slide or this slide deck alone without having to go anywhere else. So with that, I'm going to take you over to MIM, which I had seen an earlier slide that I don't think most of you are using MIM, and that's not what I trained with either. There's a few really nice things that can be done in it. There's also some that are a little bit different, but by and large, it's fairly similar to others. Here you can see the cross. Oh, sorry, go ahead.
Oh, and right before we get into this, there's 2 more questions, if that's okay.
Oh, sure, absolutely.
Julius has a good question. What bladder volume do you consider full enough? Do you have any tips to maintain reproducible within daily treatments? Frequently at their center, the prostate cancer patients have problem with urination. Thank you.
Yeah, so we also struggle sort of in the same way. And so typically our rule of thumb is if 10 is full to bursting, we tell them that we want their bladder to be at about a 7 or an 8, where it's enough that they can maintain that for their time on the table. Often in the first day, because there's so many films and everything and all the setup, we will get a slightly fuller bladder. There's no one rule. I know at the sim, I will look at the bladder and see how full it is. And I will talk to the therapists who have been setting them up in the sim, say, gosh, if it doesn't look very full, how's he doing? Is he able to tolerate a little bit more, and sort of see where we can get it? That's been the most successful. There's other times where I think, especially early on in my practice, I would try and push a little bit more if it looked small. But if they're totally uncomfortable and they're not able to hold it, then that's not something they're going to be able to do day after day. Re-education and coaching, and one other thing that can be helpful during treatment, if you're not able to get it to the same level where it was during the simulation, is sometimes even showing them the image and sort of this cross one of this is where it was and this is where we need it to be. We will add bladder minimums with dosimetry, which is a made up arbitrary line that we sort of put, and I've seen people do it in different volumetric ways. But basically the premise being, if I'm meeting all my constraints, how much smaller could the bladder be and I'm still meeting all my normal tissue constraints? Again, depending on how far away someone's coming from and their specific situation, there's times where I've given someone a break that day because they just weren't really trying and their bladder wasn't great. And I didn't think it was sustainable throughout their course, versus there's times where people are trying so hard and they just have a small bladder and that's all they're able to do. And especially post-operatively, these guys struggle. So unfortunately, there's not one definitive answer, but I would say definitely work with the patient to find out how they're doing, if they're able to do anything differently, and also avoiding stimulants. They tend to be very sensitive to caffeine, alcohol, and some of the other stimulants during their treatment.
Okay. Yeah, hopefully that's it. There's no clear right way.
There's not,
I think, as Dr.
yeah,
Puckett
there's
is
not
saying.
one answer, but yeah,
Working with the
that speaks
patient
to it. Yeah.
and trying to make it reproducible and comfortable is the most important thing. And then maybe one more question before we move on, related to simulation. What oral contrast are you using in your center? I'd like to ask whether 60 to 90 minutes is enough time considering the process of fluid into the bowel.
Yeah, so we use 60 to 90 minutes too. I think that's accurate and adequate for going into the bowel. I believe it's, oh shoot, it'll come back to me. I can't think of the name of it right now. And I know we switched from the old one that we were using. We had a new vendor at the hospital. And so I'm not sure actually of the name of the new one.
It's okay. Okay, great. Maybe for the sake of time, we'll save some of these other questions towards the end. Continue,
Okay.
Dr. Puckett.
Sounds good. So here we have our view. Okay. And this is one of the ways I like to look at it most. I have my big axial, but I can also still see what's going on in other planes. Originally, when I was first contouring, I wasn't very good at using the crosshairs function, but I know this is present on just about every contouring that I've ever used. And one thing in post-operative is the bladder is reconnected lower, and we'll go through that, but I can still see fluid here. And so it's really nice to be able to see in all three planes, sort of how does that look going down? Along the lines of what I said too, bringing in both penile bulb and your rectum, this will help set up my boundaries as I'm going through, where, especially down in here, it just gets really mucky after someone's had a surgery and really hard to delineate exactly where does everything go. So we'll walk through that. And in the interest of time, I'll just sort of leave that there and let me come back. Okay. So penile bulb, again, I'm not going to spend too much time on this, but tends to be either round or a teardrop shape. And unlike intact prostate, where there is a gap, which is a muscular gap, in this case, you're going to be treating pretty darn close to the penile bulb. And so I put this back here too, just to kind of illustrate that. So the prostate was here, and here's the G diaphragm. And so your anastomosis is going to be kind of right there. And so here is your bulb. And you can see where that space used to be, but in this case, it's not going to be because it's post-operative. So again, now we're going to talk about, we're going to get into the heart of it and the meat of it. So like I said, this VUA, or the vesiculourethral anastomosis. So this is where the bladder was reattached to the urethra after it was resected. This is a high risk of recurrence, so it's an especially important area to cover. And visualizing it can be really tough on a CT. If you have an MRI, that's fantastic. Otherwise, the other thing that I do, and I'm going to come back to MIM here, is I mentioned how this view certainly helps me. The other thing that can help, and most will have this function, I'm going, here is a contrast tab, and there's different ways to do this on different ones. But by and large, this hump here represents where most of the values that I'm looking at are. And so by slightly tweaking it, you can see here where now the fluid level really pops out to me. And one of the key ways to figure out as you're going down towards the base, and eContour in the resource that we've sent has a really nice kind of step-by-step to take you through this. But here I can clearly see fluid. I don't have to imagine it because I've sort of changed the window and level such that I can see it. I still see it. It's a little tougher here. I'm going to zoom and see. I think I still can. And so now I'm below it. And within your system, you should have millimeters. I can see them up in this corner, and one of mine's covered here too. But as you go down, depending on how many it changes by, so on this, it's 2, that will tell me how my slice thickness, if I didn't already know. By and large, the rule is that you want to go at least 8 to 12 millimeters below that. So instead of being complicated, this is the last slice where I would say I see a fluid area at all. And so I'm going to go 1 centimeter below, or 5 slices. So I'm literally just going to click down 1, 2, 3, 4, 5. And so when I look at that, I can see I'm above the penile bulb, and some directions will say start 1 above the penile bulb. So immediately we have a discordance, which is very frustrating if you're looking at an atlas like, well, which one do I use? Their range was up to 1.2. 2 to go down below that area. So, oops, sorry, and I clicked on the wrong thing. Here we go. So I clicked one more, and depending again on this person's individual features, you may want to cover lower than you normally would, but otherwise this would be my starting place for my contours. And so I've put on here some sort of common mistakes so that we can go through. So this is person A's contour for this one. Immediately when I look at it, one thing that strikes me is, oh gosh, they did start, a ways higher up from the penile bulb. That might be a red flag to me that I need to be covering a little bit more. So I would say that's too minimalistic. And so the correction for that is that I would add that in. Let's see here. Okay, here we go. And we start out with sort of, it's not quite an ovoid, but we would start here and we're coming up. And again, coming up here to where we think surgical changes could be present. And it's tough because on CT, there's not some magical thing that you can see exactly where it is. Once we start to come back up to a fluid level, then we sort of know where we are. I would also say this one looks really small around sort of that central area, where in intact prostate, you start with these very specific shapes as you get near the GU diaphragm and go from there. But here, you can't really see, and so you're going to want to err on the side of being generous when in doubt. And as you come up again, and we're getting here, you're bounded by the muscles. And so I have a good slide on this. I'll come back here. So here are our muscles, and again, our borders. So anteriorly at this level, we're going to go all the way up to the posterior edge of the pubic bone. So that's well as illustrated here. And posteriorly, we're going all the way to the rectal wall. We want to laterally include the levator ani muscles, but not the obturator internus. That's sort of going to be at the outer edge of where we're going. And so I'm coming back here. So now with that in mind, it's like, oh gosh, I want to bring this more anteriorly to make sure I'm covering. And also this should be back more towards the rectal area. So you can see we've really expanded from what this sort of, I would call it the minimalistic approach was that someone had here previously.
And can I make one comment, Dr. Puckett?
Oh, absolutely.
So the question that we were testing about, I with the Zoom poll, I think was asking about the posterior aspect. And so at least the way that I've been taught, you want to go back to the rectal wall. And then not just the rectal wall here and you're done, but actually consider all the parts of the rectal wall that are kind of in this kind of like front half of the rectum. This is not the case where, at least how I've been trained, where you want to try to be too cute and to try to spare the rectum too much in that corner, because you can have recurrences there.
Yeah, no, that's a great point, Ben, and thanks. And I love that you have your little red one too, and you can mark as well.
Because sometimes I just want to make like a nice circle. So it like match yin and yang with the rectum, but you have to cover that corner right here where there could be recurrence.
Exactly. And that is a very common, I mentioned the anastomosis is one common spot. The other is so close to the rectum here. And again, looking at your operative report will tell you where your highest risk area is for that patient. You don't want it to be, for example, like flat, like you may remember there was one that kind of looked like this. That's undercovering. You want it to dip back, but there's also an art to that where you don't want to be overly generous, for example, all the way back here. That's too much. But these tissues sort of in this front part of the rectum here, I would say up to there, definitely want to include. The other thing you want to be mindful of is on your GTV or CTV, not to overlap with the rectum. You have to choose which one it is. If you think it's really rectum, then contour it as rectum. If you think it's really target, then contour it as target. But occasionally I'll see residents who do this. And this is going to give you a conundrum when you go to your dosimetry plan, because you can't have it both ways. You have to pick. Your PTV will ultimately overlap with this, but at least at this stage, if you want to meet your constraints, you want to be mindful to not have it both ways, that it should be one or the other. So moving up, again, we said we'd probably be a little bit more generous anteriorly here. And I have a couple cases, and same here. They haven't done quite enough in here because this is an intact prostate. They basically, what they did is they contoured it as if it's an intact prostate, and you're trying to be very mindful of actually respecting those borders. But here it's been operated on. And so I'm just going to come up, and here you can see clips. You definitely want to include this area by the clips. And so this was my quote unquote, my mistake version, my minimalist mistake. And here is what ultimately was contoured. So you can see how this person's really hasn't been generous enough in this region, and kind of coming back, they're also a little bit skimpy right in here. And then again, this person has brought their contour back way before we got to the top of the symphysis here. So that wouldn't be enough within the bed, but I'll sort of pause there and come back, because now we're getting to the area of the pubic symphysis. And yeah, thanks, Ben. I see your line there too. This is, yeah, again.
Trying to make it straight.
Yeah. And it won't be perfectly straight because you're going to come back over a few slices, but it should be pretty close. Okay.
So going kind of up. Yep.
Yeah, beautiful. All right, and now I'm going to go back to my slideshow. Okay, great. And so again, below the pubic symphysis, we talked about this, how we're going to try and aim for about a centimeter-ish below the VUA. And if you can't, then you go a slice above the penile bulb. And so the bladder. So in intact prostate, you're not necessarily trying to include a lot of the bladder. Here, especially in the lower slices, you are absolutely including the bladder in your field, because that's part of where it was operated. And again, they have to meet once the prostate's out, the bladder to the urethra. So that is at risk. And then this shifts at the level of the pubic symphysis. And we started to see this in this one that we just looked at, that as we kind of come back around there, now we're going to go back to having 1 to 2 centimeters of the bladder wall. And so let's do that. Okay. And so let's see here. If you look here on this one, you can sort of see the level we're at. So I'm going to bring it back down. So we're coming up, and I'm going to turn off this one, and we'll use our more realistic contour. So this person has gone up. Oops, now I'm going too far down. Okay, and here we go. And we got the bladder, and we reached the top of the pubic symphysis. And now what we're doing is we're starting to hone back. So this is the first one where we're just sort of at the edge there. And then as we come back over the next few slices, we're pulling it back. We're past the level of the pubic symphysis. So we're pulling back. And now we should be getting, and I typically will do it this way just because if you expand in 3D, I'm not so worried about the center part of the bladder, but the posterior 1 to 2 cm. And this one has an option where I can actually tweak it. So one thing I sometimes will do is give myself about a centimeter cursor. And so I know at the bare minimum here that I'm getting a centimeter. And that's one way to do it. Others will do it in other ways or just eyeball. So that tells me that I'm in the right, oops, sorry, and I'm going in the wrong direction. And here, this might be a little bit skimpy here because I'm just using this one and kind of coming around, and any post-surgical changes, again, laterally. And again, this is not where you want to be too cute. You don't want them to recur, and they have some risk factor, which makes them more likely to recur and or already significantly rising PSA. I'm sorry, I keep on going the wrong direction. Here we go. And so we're coming up, we're covering clips, getting that last, and it will usually include about 3 cm above the pubic symphysis. So if you were to go level with this, you can measure it and it should be about 3 cm, and then you've done enough. So
And you can see that in the sagittal slice. Yeah, that's great. And I like how you pointed out the clips, Dr. Puckett. That was something that didn't occur to me at first when I was drawing these. I just saw random white things. I didn't know like exactly what to think, what's going on. But those are clips from surgery and you got to cover those.
And you do, although one of my next cases will also kind of go into that a little bit, because sometimes there's an awful lot of clips.
Yes.
And they may be within the area that is most at risk or not. So this is just sort of a re-illustration of what I showed in this specific region around the area of the pubic symphysis. You definitely want to include all the clips that you see because that is at risk. And then here is an illustration of how it would look as with you including 1 to 2 of the bladder wall. So yeah, I was curious for this group, do you have anything else that helps you when you're doing post-operative contouring? And unfortunately, I didn't think to put multiple. So I guess if you have multiple that you use, then whatever is the most common.
So yeah, thanks everyone. We have MRI, urethrogram, just CT, or other. So yeah, choose whatever is most common or helpful that you do use or interested in that. And then while people are answering, maybe we can take a stab at one of these questions. One is T4 a factor you would consider to include nodes? This is a good question.
It is. I mean, it's most common that if it's T4, there's other high risk factors alone. So that's an interesting question. If it was T4 alone and nothing else, would I do it? I don't know. To me, that speaks of something more aggressive, where if I'm on the fence about it, I typically will. I don't know that that's a evidence-based answer though. So take that with a grain of salt. Anything that I consider very high risk would lean me in that direction. There's also nomograms that I will use to see if I can delineate what I think their risk of nodes. Often in a post-operative setting, they have looked at nodes as well. So if they did a diffuse resection where maybe they took out 10 nodes and none of them were positive, then you have to think, well, gosh, is there likely to be anything else that would be there? So it is specific to an individual case and the surgeon. T4 alone, yeah, that's a tough one. I probably would say yes, but it's assuming again that something else looks aggressive.
Yeah, I think that's a safe answer. I think that's a very practical response. You know, we don't know all the details, but most likely, yeah.
Yeah.
And okay, great. We have lots of respondents. So we'll go ahead and share the answers. Here you go.
Great.
So yeah, go ahead.
Yeah, it looks like lots of you are using MRI too, which is really wonderful. And perhaps I should have included it then too. I actually did try and bring in one that had both the CT and the MRI, and I had a technical difficulty with it, so I won't be able to show that case, but that's fantastic. And there's a couple different atlases which have been shared in the intact setting, like the McLaughlin paper and others that show the anatomy. And again, it's just anything else that can help tell you you're in the right spot, treating the right area. If there's anything suspicious like a nodularity, to make sure that you're broad and covering that and in your specific plan. So yeah, thanks for answering. Oops, let's see if I can get my mouse back. Here we go. Okay, great. So lastly, we're getting above the pubic symphysis now. And this can be one spot that's a little tricky for people too. You have the mesorectal fascia back here, and you're bounded again by your muscles out here, the obturator internus. And there's a number of clips. And as you go further superior above this, Typically you will cover, as I mentioned, 3 to 4 centimeters, and any seminal vesicle remnants, which usually fall within that, but very rarely they will come sort of more back posteriorly or something. And so if that was the case, I would cover those by and large. And so actually, before we go, sorry, was there a question? Or?
Was there a question? Okay, no question.
Okay, I'm going to
Except
go
in the chat, but we'll save those.
Okay, I'm going to go to one more case then. Let's see. Okay, so this is a little bit different case, a little different anatomy. And trying to get my zoom. Sorry, it's kind of covered by the board. Okay, but great. So we look at this originally, and just like the other one, the window's okay. This is on a soft tissue window, but I'm going to play with it just a little bit to see if I can get it to pop out a little bit more, and just that little tiny tweak, and look at the difference in the density there, where you can really see it more clearly. There is a clip here, and I'm just going to go ahead and turn on my, okay. So this is the contour that was done, and it, it definitely looks different than the other one. If you really sort of squint at it hard, you could almost make out sort of a toilet bowl shape to it, but it does look a little bit funky. So let's look at that. And I'm going to put on some of our other features to help us. So we'll add our rectum, and we're going to add our penile bulb. And so this penile bulb, someone had contoured it a little bit differently. It's a little tiny, so I actually had done a second one. Yeah, usually it's more of a rounded / teardrop shape. But again, there's differences in the way that people do it. And by using my crosshairs, I can see I am in the right place. And so this person's gone all the way down to the penile bulb, I guess arguably the slice above, but it looks a little bit low as compared to where we last see the urine. So I think I can see it maybe here, 1, 2, 3, 4. And so, yeah, they've gone a little bit more. A little bit of that is variation. I would say it looks a little bit over contoured to me. It's not that we want to be cute, but they're pretty broad even before we're coming up to the symphysis. So, but this in here starts to look okay. As we mentioned, you shouldn't really be overlapping with the rectum. You have to decide which one it is. Okay. So if I were correcting this for a resident, I would do that. And you still kind of see that shape where it's draping a little bit, but not too much to the level of the rectum. And so and if you ever do a case and look at it and kind of like this, it's like, well, gosh, actually, there's a bunch of things that are different. It's generally easier to make a new one, still leave that one on and use it as a guide, but I would not actually correct this one slice by slice. If I were doing it with a resident, I would make my own and sort of use this, to see what they've done as well. But it's going to be a lot of labor and pretty irregular if you try and do it per slice. So coming up here, one thing I noticed as we talked about, you do want to cover the levator ani muscles here, but they've gone all the way out into the obturator internus out here. So that's a little bit more generous than I probably would be. We are covering our clips. Same thing, they start to dive just a little bit more than I would, and again out into the other muscles. And all those things, because you're adding further margins to this, it just makes it tougher to do a plan where you're going to meet your constraints. There are cases in post-operative settings where you do your darndest and you're not able to make it. And so then, for example, if I was going to take it to 66, is it reasonable to take it to 64/80? It might be, that's still very reasonable, and there were trials at that dose. But some of those considerations have to come into play if you're really struggling with anatomy. Otherwise, again, this person is just over generous. They're contouring a little bit too far back into the rectum. you definitely want to include those clips there, but they're also kind of coming out into the muscles here. So this is just an example of, you want to be generous, but it's still a little bit over generous with that in mind. I'm going to come up a little bit higher, and same here. If you look here, we're past the pubic symphysis when we look on the sagittal here, and it's not that we're wildly above, but you want to start bringing that back right away, because that anterior bladder is not at risk. And so I would do more like this slice. And as we come up, you can really start to bring it back. And we're aiming again for ultimately that 1 to 2 centimeters that we're going to get. So you can see how that starts to change the shape of what we do. And by this point, and again, they went way over into the muscles here, which is going to give you dose over here to the bone that you don't need to do. So I'm just going to shape up this slice kind of to show. So afterwards, I would cover these clips, and this person happened to have nodes too. And so there would also be coverage for nodes. But if you're just doing this alone, we'll take it out of the rectum again, because we're on our main CTV. And so this is not the most beautiful in the world, but roughly what we look like here.
Yeah, no, it's great to see how you would correct and kind of modify it. I think in case anyone spaced, she's talking about the 1 to 2 centimeters, like right here. Yeah. So the posterior part of the bladder. This isn't a ruler, so I don't know what its actual distance is, but you could also see that on the sagittal slice that you do want to cover a little bit of the bladder, but you don't want to cover like way out into it.
Yeah. And also, if you want to do 1 or 2, you can set your cursor at that. So this would be 2 if I wanted to cover 2. And most of them do have that function one way or another. So I will take this one off, or actually before I do, let me go to the real one just to show that and kind of compare between the two. And so here you can see with the corrections, now we're getting pretty close to what the actual one was. And as we come up here, we're going our 3-4 centimeters up from, like, again, I don't think I can do it the way you do it, Ben, but just sort of coming across straight here. And then if you were to go up, you want that distance to be about 3 to 4 centimeters, where here, this blue one is too much. And one thing that they often will do in addition to the area that we're treating, and certainly that's reasonable to include, but there are vessels that get clips. And so these clips, unlike some other surgeries, are not intended to be a guide to where the high risk areas are. You can see up here. And so this is beyond what we would do in the treatment. That we're chasing clips that are outside of what we're expecting for at-risk fields. So it's very common that you see clips even like way up. And again, some of those are just small vessels that have been clipped. And if they're way up there, you're not going to chase them beyond that 3 or 4 centimeters unless you had something that explicitly said there was disease there. So that's good for that one. I know I'm getting tight on time, or actually probably over here too. So let me just come back and go here. So hopefully this will resonate. This is our sort of like afterwards here. So this should look more similar to what we did. And actually I noticed in all of them, we said the posterior border is actually the back of the bone. So all of these arguably are a little under contoured, but with respect to the posterior right here, that looks pretty darn good, where this is a little bit under here. Again, they've been a little too skimpy. They should be covering the muscle out to here. And here they tried to avoid the bladder, which was contoured in green, and just do this inferior aspect, which we know the bladder does get included. So I think these are really great examples to learn from. And I know I learned the most from making the mistakes. And so I can see why they would make these mistakes and then what the path forward is. And then same with these, you can see this person hasn't come up far enough in the bladder. They started honing back way before they reached the top of the symphysis. These included here, but they forgot this whole posterior element where the seminal vesicles were and the remnants are. And both of these two had done that. And then this one is just too far anteriorly in the bladder. That's not at risk. So we come back to our favorite shape, the toilet shape.
Yeah.
And you know, I recognize also that toilets are different across the world too. So don't be fooled. You don't want a more petite potty or something that doesn't have the tank on top. This is the shape that you need. So take home points. You know, this is very different, or there's similarities, but there's also differences to contouring intact prostate. Make sure you're including that lower bladder and the seminal vesicles. Always, 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 if you're having trouble, go back to the crosshairs, put it on your trouble spot and scroll a little bit on the axial, scroll in those other views, and you can usually figure out if you're in the right place or not. We didn't get into it too much, but the last step after you're happy with your volume is, again, to look back at that operative report and see, for example, if someone had a lot of disease at the apex versus both seminal vesicles were involved, you may want to tailor to be a little bit more generous in whatever that high risk region is. And that's what you should do. So that's the last step of making sure you do a great job. And then at the end, anytime I know I treat something that I don't usually treat, I will reach out to my colleagues, and if I'm not sure, then have someone else look it over. I know there's a lot of peer review, which may include your institution or regional or national or even international, but don't be shy to reach out and say, hey, does this look right? Is anything funky with this? Because in the end, you're trying to do the very best you can for your patients, and that's the best way to do it. And don't forget the references, which are available on here too. I use them, even though I've been doing this for years, I still look at them again when I'm doing these cases, because I don't do it one every single day. And anatomy is variable. And so you want to make sure that you're contouring adequately and generously in the post-operative setting. And I think we talked about each of these potential problem areas. I'm happy to take questions, and depending on interest, I do have one more case, but I'll also give my thank yous here.
This is so great. Wow. Thank you so much, Dr. Puckett. Really enjoyed today's session, and we're not quite done. We have a number of questions, but yeah, really liked the way that you walked through. It was so nice to see examples from some of the residents that you're mentoring, and how to, you know, these are universal common mistakes. So it doesn't matter what part of the world you're in, we're still learning, and we deal with the same prostates here. So we have one question. I think I'll start. One is, do you routinely use PSMA PET CT as an additional tool?
We are just starting to. At our VA center, we got PSMA, I think 8 or 9 months ago. And so interestingly, in the post-operative setting, I have not yet had a case where I use it, but I absolutely would, to further guide what I'm doing. And any resource you have available to you, including that one, can be really, really helpful. So I would say yes, if you have the option.
Mm-hmm. And I can speak to that a little bit. At UCSF, we have Dr. Tom Hope, who helped make the PSMA scan mainstream. So we've been using it for a while, and we do use it in the post-op setting regularly, but it's not very sensitive when the PSA is below 0.2. So sometimes you have an early recurrence, and you only get one chance to use the PSMA scan, because our insurance companies won't let us use it multiple times. It's expensive. So we want to wait until it's just the right time to use it. So usually we'll wait until the PSA gets to at least 0.2. And then we can see exactly if there's a prostate fossa recurrence. It can help us direct and decide about our radiation volumes and our dose. To that point, there is a question about what dose can you give to post-op prostate with PSMA avid nodes recurrence. This is a challenging question, Dr. Puckett. I don't know if there's like it's kind of a debate, so we may not be able to safely provide like a recommendation, but if you have any thoughts you want to share, Dr. Puckett, you're welcome to.
Yeah. At our institution, the feeling is whatever you can do safely. And so a lot of that goes with the imaging that you would have available. At our VA, for example, we don't have the same tools that we have over at our academic center. And so I would be a little bit shy to boost too high. I've seen it at our center, we're probably comfortable up into about 56, and that would be the central part of the node. I know there's places that go way higher than that. By and large, what I've historically done is up to 50/40 or up to 54, not as a PTV, but centrally again, and that data is evolving. So that I don't feel comfortable making a recommendation for your center because there's so many factors that would go into what can be done safely. But I do think that's evolving, and also the places that are taking nodes higher are sharing those resources and how to do it and what stipulations to look for in dosimetry. And so I'd say over the next 2 years, I expect there to be more information, but hopefully that's at least sort of a ballpark of at least where I'm at. And Ben, you can speak to that too if you have something different.
No, I think you nailed it. There's no magic right dose, but you want to do a higher dose than you would normally do to like compared to an elective volume, and you want to make sure that dose is safe. Okay, this is an interesting question, maybe a good one. What if the patient had a partial cystectomy? How would you contour differently? Or like
Oof.
if the patient had a fixed small bladder?
Yeah, so I definitely have had patients who are in a situation where they just don't have much filling at all. Their very best is small, and in the end, I contour it the same way, and I add the same margins because they're still at risk, and whatever that risk and that risk area is, if I haven't treated it and they recur, then I've done them a disservice. I do counsel them that their risks will be much higher and their risks of toxicity are higher. But again, assuming that there isn't some magical way around it, which I haven't seen, that would, unfortunately, you're just accepting a higher risk if you're in that situation.
Great. We have another question. This is both from Dodie and from Flora, wondering about sort of post-op indications for radiation. Besides positive margin, do you also look at other parameters in the histopathologic report and post-op PSA level? And Dodie kind of says the same thing. Aside from positive nodes, high-risk disease, what other disease features would you consider in treating the pelvic nodes?
So there are nomograms, and I think Memorial Sloan Kettering has one, and maybe I wonder if I can even like Google pull it up here. But I think it's called something very similar to prostate nodal risk or something like that.
Yeah,
and it takes into account
I
all of those and gives a value.
Yeah, I think I have that here.
Yeah, they have a pre and a post. And so you can consider either pre-factors or post-factors if you have it to help give you a sense of what that risk would be. It's not perfect, but it will give you, to my knowledge, one of the more specific, and it takes into account, for example, their Gleason score. Oh, actually, let me share this. So this is one of them, and I can share, let me share this in the chat too, just if anyone wants to play with it.
Oh yeah, I shared the salvage one.
Oh, great, yeah. And yeah, I may have shared the wrong one. There's a whole pile of them depending on the very specific situation that someone is in. And so it has their PSA level, their Gleason score at surgery, where the margin's positive. and sort of all the different features, including were lymph nodes involved. And so I will look at this. I've also looked at sort of their pre-op features as well to give me the best sense I can of what their nodal risk level. My comfort level is generally around 10%, where if someone's over 10%, I tend to include the nodes. You have rare patients where, for example, they're very risk averse and they don't want any side effects. And then I will talk to them a little bit if they're on the cusp of, generally I would include the lymph nodes. It does put you at a little bit higher risk of GI toxicity and so forth. And I've had gentlemen who have refused to have their nodes treated, sort of hearing that, and others who say, yeah, go for it if it might rather do that. And depending on the patient population, some people are more or less comfortable with that, but it has helped me in a few occasions where I've used that nomogram.
Wonderful. Another is, do you commonly use the Roche formula in determining prostate bed radiation?
So I used to, and I don't anymore. I will use these instead.
Mm-hmm.
And actually, I think it continues to evolve to, I really encourage you to look at the NCCN guidelines. Their radiation indications and post-op prostate has changed and is really nice now, where they get into the nitty-gritty. And I might actually, let's see if I have that one up too. There we go.
And then there, I mean, these are all great questions. There's another one that was sent privately in the chat. Has to do when there's high nodal burden in the post-op report. Do you usually include the para-aortics, or do you leave that to adjuvant hormonal therapy?
Not unless there's some clear indication that they would be involved. By and large, I have not. And I know there's different centers that have approached that differently, but that has not been, at least for me, my practice.
Mm-hmm. Yeah, I'm getting the sense that T4 disease, nodal involvement, patients who had partial cystectomies, I mean, definitely a kind of a, on average, higher risk population than I think what I see on a regular basis. So yeah, you guys are getting all the hardest cases.
Yeah.
Yeah.
Those are really challenging, and
Mm-hmm.
bad disease, by and large, my rule of thumb is bad disease is bad disease. If you see something that makes it bad in a significant way, such as T4 is really bad disease. And so I do take that into account.
Mm-hmm. Wonderful. Well, are there any other questions for tonight? These have all been really nice discussion. Thank you everyone for participating.
Thank you everyone. Those questions are fantastic. This is what I was alluding to in the NCCN with their principles of radiation. I think they've updated just recently, and they go through some of the nitty-gritty, which you're honing in on. If there's so many specific situations of what if they have a very low PSA, depending on what the situation is, would you change your dose or when would you do it? There's also Decipher, which is genomic classification, which I didn't really get into and can be helpful. But I really appreciate everyone's attention and the opportunity to present tonight. It's great to be here with you.